Gastroesophageal reflux disease, or GERD, is a common condition that affects millions worldwide. It occurs when stomach contents flow back into the esophagus, causing symptoms like heartburn, regurgitation, and even difficulty swallowing. For many, GERD is more than just an occasional discomfort. It can significantly impact daily life, leading to chronic pain, sleep disturbances, and even complications such as esophageal strictures. While medications like proton pump inhibitors are often the first line of defense, a substantial number of patients continue to struggle with symptoms despite treatment. This persistent form is known as refractory GERD, and it presents unique challenges for both patients and healthcare providers. For those with refractory GERD, standard treatments like proton pump inhibitors often fall short. Even with optimal dosing, about 30–40% of patients continue to experience symptoms. This can be frustrating, as ongoing reflux can disrupt sleep, cause persistent discomfort, and increase the risk of further complications. When medications are not enough, surgical options such as fundoplication are considered. However, these surgeries come with their own risks, including post-operative complications like dysphagia, gas bloat syndrome, and diarrhea. As a result, there is a growing need for alternative, less invasive therapies that can effectively address refractory GERD without the drawbacks of traditional surgery. In response to the limitations of medication and surgery, endoscopic anti-reflux therapies have emerged as promising alternatives. These include techniques like radiofrequency ablation and transoral fundoplication, which aim to strengthen the barrier between the stomach and esophagus. However, these methods are not without challenges. They often require specialized equipment and expertise, making them less accessible in many clinical settings. Additionally, their long-term effectiveness and safety profiles are still being evaluated. This has led researchers to explore other endoscopic options that are both effective and practical for widespread use. Anti-Reflux Mucosectomy, or ARMS, is a novel endoscopic procedure designed to treat patients with GERD who do not respond to medications. First introduced by Inouye, ARMS involves removing a portion of the mucosal layer at the gastroesophageal junction. This leads to scar formation, which helps tighten the junction and reduce reflux. Unlike traditional surgery, ARMS is performed through an endoscope, making it less invasive and generally safer. Over time, modifications to the technique, such as cap-assisted endoscopic mucosal resection, ARMS-C, have further improved its safety and effectiveness. Cap-assisted endoscopic mucosal resection, or ARMS-C, is a refinement of the original ARMS technique. In ARMS-C, a transparent cap is attached to the end of the endoscope, allowing for better visualization and control during the mucosal resection. The procedure involves marking the area to be resected, lifting the mucosa with a special injection, and then removing it using a snare loop. This approach minimizes the risk of complications and enhances the precision of the resection, making it a preferred method for many endoscopists treating refractory GERD. A recent study set out to evaluate the short and long-term outcomes of ARMS-C in patients with refractory GERD. Conducted at CHA University Hospital in Korea, the study included 115 eligible patients who underwent the procedure between 2018 and 2022. The primary goals were to assess changes in GERD symptoms using the GERD-Q questionnaire and to track reductions in the use of proton pump inhibitors. Secondary objectives included evaluating physiological measures such as the Demister score, acid exposure time, and esophageal motility. The study also aimed to determine the safety profile of ARMS-C over an extended follow-up period. To ensure the study's validity, strict criteria were used to select participants. Patients had to have persistent GERD symptoms despite adequate use of PPIs. Exclusion criteria included previous esophageal or stomach surgery, pregnancy, major psychiatric illness, large hiatal hernia, and severe esophageal motility disorders. Before undergoing Arm C, all patients received comprehensive assessments, including high-resolution manometry, 2-4-hour pH monitoring, and endoscopic evaluation. These steps ensured that only appropriate candidates were included, minimizing the risk of complications and maximizing the potential for meaningful results. Before the Arm C procedure, each patient underwent a thorough preoperative assessment. High-resolution manometry was used to rule out major motility disorders, while 2-4-hour pH monitoring measured acid exposure and symptom correlation. Endoscopic evaluation checked for esophagitis, Barrett's esophagus, and hiatal hernia. The GERD-Q questionnaire was administered to quantify symptom severity. These diagnostic tools provided a comprehensive picture of each patient's condition, ensuring that the Arm C procedure was both necessary and likely to be beneficial. The Arm C procedure is performed using a high-definition endoscope equipped with a distal cap. The process begins by marking the area around the gastroesophageal junction to be resected. A submucosal injection lifts the mucosa, making it easier to remove. The lifted tissue is then captured with a snare loop and resected using electrosurgical current. If bleeding occurs, it is controlled with coagulation techniques. The procedure is repeated as needed to achieve the desired extent of resection, typically covering 60–80% of the circumference. This minimally invasive approach aims to remodel the gastroesophageal flap valve and reduce reflux. From 2018 to 2022, 120 patients with refractory GERD were assessed for eligibility. After applying exclusion criteria, 96 patients underwent the Arm C procedure. The group included both men and women, with an average age of 47.4 years and a median symptom duration of 4 years. Many had additional conditions such as Barrett's esophagus or ineffective esophageal motility. These diverse patient backgrounds provided a robust sample for evaluating the effectiveness and safety of Arm C across different clinical scenarios. The primary outcome of the study was a significant improvement in GERD symptoms, as measured by the GERD-Q questionnaire. Scores dropped from an average of 10.67 before the procedure to 7.55 afterward, indicating a meaningful reduction in symptoms like heartburn and regurgitation. Additionally, 36 out of 96 patients were able to reduce or completely stop using proton pump inhibitors. These results highlight the potential of Arm C to provide real relief for patients who have not responded to other treatments. Beyond symptom relief, Arm C also led to improvements in several physiological measures. The Demister score, which quantifies acid exposure, decreased from 4.75 to 3.9. Acid exposure time was reduced, and the proportion of patients with intact esophageal peristalsis increased from 78.4% to 89.7%. The median grade of the gastroesophageal flap valve improved, and lower esophageal sphincter pressure showed a positive trend. These objective findings support the subjective improvements reported by patients, reinforcing the effectiveness of Arm C. Long-term follow-up is crucial for assessing the durability of any medical intervention. In this study, 22 patients were followed for at least 2 years after Arm C. Impressively, 86% of these patients continued to experience improvement in their GERD symptoms. 5 had no reflux symptoms and did not require PPIs, while 14 maintained a reduced PPI dosage. Only 3 patients showed no improvement, and importantly, no serious adverse effects were reported. These findings suggest that Arm C offers sustained benefits for many patients. To better understand the range of outcomes, patients were categorized into 3 groups: complete response, CR, partial response, PR, and no response, NA. CR patients showed both symptom improvement and reduced PPI use. PR patients had improvement in either symptoms or medication use, and NR patients saw no benefit. Out of 96 patients, 86 experienced either a complete or partial response, while only 10 had no response. This categorization helps clinicians set realistic expectations and tailor follow-up care for individual patients. Safety is a top priority in any medical procedure. The ARM-C technique demonstrated a favorable safety profile, with no serious adverse effects reported during the study. 9 patients developed simple strictures, which were effectively treated with balloon dilatation. Importantly, the procedure did not degrade lower esophageal sphincter function, and the rate of complications was much lower than that seen with traditional surgical approaches. These results underscore the potential of ARM-C as a safe alternative for patients with refractory GERD. ARM-C is not the only endoscopic therapy available for refractory GERD. Other options include the Stretta procedure and endoscopic fundoplication. While Stretta is minimally invasive and has a low rate of adverse events, its high cost and uncertain long-term efficacy limit its widespread use. Endoscopic suturing methods are innovative but require expensive equipment and may not provide lasting results. Compared to these, ARM-C stands out for its cost-effectiveness, accessibility, and sustained symptom relief, making it an attractive option for many patients and healthcare systems. The effectiveness of ARM-C lies in its ability to remodel the gastroesophageal junction. By removing a portion of the mucosa, the procedure induces scar formation and tightens the junction, reducing reflux. This anatomical change is complemented by improvements in esophageal motility and lower acid exposure, as shown by the study's physiological measurements. The result is a restored barrier that prevents stomach contents from flowing back into the esophagus, providing lasting relief for patients. While the results of this study are promising, there are important limitations to consider. The research was conducted at a single center and did not include a randomized control group, which may affect the generalizability of the findings. Additionally, the long-term safety and efficacy of ARM-C require further investigation, as only a subset of patients was followed for more than 2 years. Future studies with larger, more diverse populations and longer follow-up periods are needed to confirm these results. The findings from this study have significant implications for the management of refractory GERD. ARM-C offers a safe, effective, and minimally invasive alternative for patients who do not respond to medications and wish to avoid surgery. Its ability to provide both symptom relief and physiological improvement makes it a valuable addition to the therapeutic arsenal. As endoscopic techniques continue to evolve, ARM-C may become an increasingly important option for clinicians treating challenging cases of GERD. Looking ahead, the field of GERD therapy is poised for further innovation. As more data become available, procedures like ARM-C will be refined and optimized for different patient populations. Ongoing research will help clarify which patients are most likely to benefit and how best to integrate endoscopic therapies into comprehensive GERD management plans. Ultimately, the goal is to provide effective, personalized care that improves quality of life for all patients suffering from this challenging condition. In summary, anti-reflux mucosectomy with cap-assisted endoscopic mucosal resection represents a significant advancement in the treatment of refractory GERD. The procedure is safe, effective, and minimally invasive, offering hope to patients who have not found relief with medications or wish to avoid surgery. While more research is needed to fully establish its long-term benefits, ARM-C is already making a meaningful difference in the lives of many. As the field continues to evolve, this innovative approach may become a cornerstone of GERD management.